Once you've made the decision that it's time to enroll into Medicare, it will also be time for you to decide upon additional insurance beyond original Medicare. That too is a critical decision because it's going to have consequences for you physically as well as financially. But it's also a confusing decision, just like original Medicare can be confusing and really overwhelming because of all the options. Getting that additional insurance can be as well. But that too can be a very confusing decision and sometimes overwhelming because of all the options. And so really that's where we come into the equation. It's our job to assist you, to really come alongside you, to explore all your insurance options and to explain those in great detail, the good, the bad, and the fine print, so that then you have the information that you need to evaluate what's going to be the very best plan for you. And once you've decided, then we will actually take care of the enrollments into those plans. And so what I'm going to do in this video is I'm going to specifically look at Medicare Supplemental Plans, and I'm going to show you everything that you need to know about those plans. I'm going to show you how they work, what they cost, and what they cover. And then I'm going to conclude by showing you how you can choose the very best plan and the very best company for your particular situation. Let's get started. Now, I want to begin by reviewing the different systems that are available to us to use our Medicare benefits. All right, the first one would be to enroll in a traditional Medicare A and B only, no other insurance beyond that. That's the first one on the list, but it's also the worst one on the list, in my opinion, just too much risk. The second one, very common today, would be someone enrolls in traditional Medicare A and B, and they get a supplemental plan to fill in the financial gaps that Medicare did not cover. Remember this, Medicare doesn't cover anything 100% other than preventive services. Anything beyond preventive, there's always going to be a balance of the bill. That would be the gap that exists financially. The third option would be to do what we call a replacement plan, given the letter C, also called Medicare Advantage plans. All right. And so again, I'm not going to spend a lot of time on this one because it's, in my opinion, a terrible option. And so we're going to spend this time really talking about supplemental plans, but I am going to kind of compare these two systems because really when it boils down to it, it's going to be either a supplemental plan or an advantage plan. All right. Now these systems have one thing in common, the similarity here, and that would be this. You have to be enrolled in A and B to be able to get a supplemental plan or to get an advantage plan. Now, for the majority of you, Medicare A is going to be no cost as long as we paid into the Medicare tax system for at least 40 quarters, 10 years worth of work. There's no premium for Medicare A, but B is going to have a premium. And so we have to pay the B premium. Right now, most people are paying $174.70 a month for their Part B premium. It comes right out of your Social Security check, or they'll bill you for this on a quarterly basis, or you can set up actually a bank draft as well called Medicare Easy Pay. But here's my point. We're paying for the Part B. Now, some of you could be paying more than that, and those are called IRMAs, income-related monthly adjusted amount. So if you're single, above $103,000 a year, married couple above $206,000 a year, you're going to have an additional premium for your Medicare Part B as well as for your Part D. All right, that brings us then to these two options, supplemental plans versus advantage plans. And so again, I'm emphasizing how supplemental plans work, but it's good to see that really the contrast between these two systems. So the first thing is you're going to see a difference in provider availability. And the reason for that is with supplemental plans, you can go to any Medicare provider you want to. As long as they take original Medicare A and B, they will take your supplemental plan of choice and the company that you choose. Not so when someone enrolls in an advantage plan, they're going to be in a network, an HMO or a PPO, and with those network come restrictions. Here, I can almost go anywhere I want because 99% of all doctors take Medicare, 100% of all hospitals do. Okay, so it's almost unlimited. The second difference would be when I have a supplemental plan, what I'm doing is I'm taking the risk that I'll show you here in just a minute, financial risk, and I'm transferring that to an insurance company. When we do that, we got to pay that insurance company a premium, no different than auto policies or homeowners policies. We transfer liability to the insurance company and we pay them a premium to take the risk from us. So it's a premium-based coverage. With advantage plans, other than paying Medicare A and B, that B premium, the majority of the advantage plans do not have a premium attached to them. Why? Because instead of paying a premium, like we would here, we assume the risk of the services that we'll need throughout the year, and we pay as we go. Go to the hospital, $350 a day copay. Have an outpatient surgery, maybe $250. Have an MRI, maybe $200. But you see the difference. We pay as we go. With Advantage, we pay a premium for supplemental plans. The third difference would be the time of the policy and portability. Lifetime policies are supplemental plans. In other words, once that policy has been approved and issued, it is yours for the rest of your life. The only way the insurance company ever cancels it is by non-payment of premium. So you pay for it, it's yours forever. It's also portable. It's attached to you. So if you move and you live in Denver, Colorado, move to Miami, Florida, take the policy with you. It's totally portable. It's the same coverage anywhere in America when you have a supplemental plan. That's different from Advantage in that those plans are 1 year at a time. It's an annual contract between Medicare, insurance company, and you, and those plans change, and they're very fluid. They come and go. Networks change. Sometimes the plans are available 1 year and they're gone the next year. So again, they're very fluid, and they're not portable. They're tied not to you, but to the service area. So if I'm in Denver and I move to Miami, I'm not going to take that policy with me. I could not do that. The fourth thing is little to no perks, meaning supplemental plans are all about insurance, all about premium, really quality insurance, very little, if any, perks at all. Advantage plan have lots of perks. They're the ones that will have the gym membership, the over-the-counter card, maybe a vision allowance or a dental allowance, possibly hearing aids. Those kind of things are going to be loaded up here. You're not going to see them here. This is really all about the insurance. Now, the fifth item I want to talk about is a pre-authorization. Now, let me clarify this. Pre-authorization means that you need some type of a service that's expensive, and the doctor makes a recommendation, and pre-authorization means that the insurance company has to approve the recommendation. In other words, the insurance company has the final say-so. This would be MRIs and CAT scans, PET scans, extended skilled nursing stays, hip replacements, knee replacements, any kind of an inpatient or outpatient surgery has to be pre-approved. And so when we compare these two, when we have an Advantage plan, about 72% of the time when you need a service, it has to be pre-authorized, pre-approved by the insurance company. When we have a supplemental plan, notice never. If Medicare says that we'll cover it and doctor says you need it, end of story. Insurance company cannot put that requirement on you. In other words, they can't interfere in any way. Over here they can because they have the final approval. Now, sometimes they approve things immediately. Other times they delay them, make an extra requirement, or maybe just simply deny it and say, we don't believe you need a full hip replacement. We're going to pay for a rod only. And so they have the final say-so in this system. Over here, it's Medicare and your doctor. And then lastly, when it comes to prescription drugs, when I have a supplemental plan, my prescription drug plan will be separate from that plan. It's a plan that you chose based upon the meds you take, the pharmacy you would like to go to. Those zip codes right now have anywhere from 15 to 25 different drug plan options. We choose those plans and we can change those annually. When it comes to an Advantage plan, they integrate that or include that. It's just part of the package. And sometimes they're very good and sometimes they're mediocre. But the point is, that's a difference between these two systems. Hey, if you found this video helpful and you want to see more Medicare information just like it, then go below, right below the video, and you can give us a thumbs up as well as subscribe to our channel. And every time I put a new video, which is about 2 every week, you'll be notified of that video, and others just like you who need this vital information will get it as well. Now I want to talk about a very important issue, and that is the very best time to buy a supplemental plan. Now, Medicare calls this MediGap or Medicare Supplemental Plan open enrollment period, all right? And this is a once-in-a-lifetime opportunity in 46 states plus the District of Columbia. So this opportunity is extended beyond once in a lifetime in New York, Connecticut, Maine, and Massachusetts. They have a longer period of time. But all the other 46 states and D.C. Give you a 6-month window. And this 6-month window says that you can get a Medicare supplemental plan 6 months before you actually start your Medicare, and then 6 months after. And the key to understanding this is that this MediGap OEP is tied to the B date of Medicare. So let me give you a quick illustration. Let's say someone's born today, 3/19/1959. I'm shooting this video March 19th, 2024. In fact, my 5th child, his birthday is today. And so he turns 21. But anyway, this is someone that's born March 19, 1959, and they're turning 65 today. That means that if they were going on Medicare, they'd be eligible for Medicare A with a 3/1/2024 date, and they'd be eligible for Medicare B at a 3/1/2024 date. And frankly, unless someone is still working or their spouse is still working and they're covered by a group plan, this is when they're going to start their Medicare. If they're covered by a group plan, if they are their spouses that has 20 employees or more on the payroll, they don't have to do anything with Medicare. But in this example, we're saying they're starting Medicare at 65. And again, we're talking about the 6 months. So again, they can apply in most states anywhere from 3 to 6 months in advance of the B date. Now, their supplemental plan's not going to start before their Medicare begins, but they can do all this in advance. They don't have to wait. So we can apply 3 to 6 months before, and our Medicare starts 3/1/24. Our supplemental plan starts the same time. And then this window of opportunity will also extend a full another 6 months. Okay, and in this 6-month window, before my B date or after my B date of 6 months, I'm in this opportunity where I can get any MediGap policy sold in my state, any letter I choose, any company I choose, and the insurance company has to approve me. They cannot deny the application. They will approve that application, meaning they have to accept you. They have to cover all your pre-existing conditions. There's no health questions asked whatsoever during this 6-month window, prior to B date, prior to or after my B date. But here's what happens. That 6-month window is going to close, and so in this example, it's going to close here. Watch. 6 months would be March, April, May, June, July, August, which means September 1 of 2024, now my MediGap open enrollment is now closed, and if I want to get a supplemental plan after that in those 46 states plus DC, now I have to go through medical underwriting. Now we're going to ask you 30 health questions. We're going to check all your meds that you're taking now in the last 2 years, get a statement from your doctor. That information is given to the insurance company, and you go through the underwriting process. And now they don't have to take you. They can say, no, we don't like the fact that you're diabetic, you've had retinopathy, neuropathy, maybe you have AFib in your medical records, rheumatoid arthritis, spinal stenosis, had cancer in the last 36 months, whatever. And there's health conditions that they can deny. They do not have to approve that policy. So that's why I'm saying this is the very best time to buy. 3 to 6 months in advance, goes in effect on the B date, and now we have 6 more months. But after that, you may have to medically qualify except in those 4 states. One more thing I want to clarify here. I want you to know the B date is the key date of this MediGap. So let's suppose somebody doesn't start fully Medicare at 65 because their spouse still working, covered by a group plan. But let's say they decide to get A only. And that was 3/1/2024, and then they decide to work 2 more years and then retire and start Medicare, and then their B date started, and that would be 3/1/2024 here. And again, the 6 months is tied to their B date. And I said this would be 2 years later. So now, instead of 3/1/2024, because they kept working, now their B date's going to begin. So my point is you're going to get that 6-month window as soon as you've started your Medicare B date. That's the best time to buy a Med Sup plan. All right, that brings us into this next topic, and that is the best way to choose the plan for you. Now, I want to clarify something. All Med Sup plans have a letter. There's 10 of them that are available right now. Now, 2 of them are not available to everyone, the C and the F plan. You had to start your Medicare, if you started your Medicare, prior to 1/1/2020, you were eligible for Medicare prior to that date, which means you're basically born before January 1st, 1955, or you're on disability. And we started Medicare before this, we can still get a C plan, an F plan. Everyone that is prior to this date was grandfathered into the system, and all 10 letters are available. But if I'm born after January 1st, 55, 1/1/55, starting Medicare after this 1/1/2020 date, now I can't get a C or an F. Those are off limits to me, but I still have 8 options. All right, now, the majority of people today that are getting supplemental plans are getting G plans or N plans. They say right now 70% get G, 30% get in. So that's the 2 that I'm going to focus on because they're the most popular. All right, now when I began the video, I told you that I think the worst choice someone could ever make is to be an A and B only because of all of the liability. And so I want to clarify that liability and then show you how that liability can be transferred to an insurance company. So if I had A and B only, I'm responsible for all the gaps in Medicare. What that means is this. I have 3 gaps on the A, 3 gaps on the B. Now the A of Medicare covers everything that's billed to me while I'm in the hospital. This would also be for skilled nursing facilities and also for hospice, as well as home health care after a hospital stay. That's what's covered under Medicare A. And so we have 3 financial gaps on the A. So if I go to the hospital, it's going to cost me a deductible this year, $1,632. That deductible is not annual. It can happen more than once in a year. Now, that covers me up to a 60-day stay in the hospital. That's all I have to pay is my deductible. But if I'm in the hospital longer than 60 continuous days, days. That brings us to our second gap. You'll see month 3 and month 4 and month 5, I have daily copays that I'm responsible for. We call these extended stays. They're pretty rare, but they happen, and you can see they're pretty expensive. And then the last gap is for skilled nursing. Remember, this is inpatient rehab after a stroke, maybe a hip replacement, an accident or injury or something like that where someone needs intensive rehab. Here's the rules. Medicare says, notice, the first 20 days in skilled nursing will not cost you a penny as long as you were in the hospital at least 72 hours or longer prior going to the skilled nursing facility. Okay, so as long as I had a 72-hour stay or longer, nothing the first 20 days. But after that, for the next 80 days, I have coverage, but I'm responsible for a daily copay of $204 every single day. They tell me right now the average stay is somewhere between about 35 to 40 days for someone that's on Medicare. So we're responsible for a daily copay during those 15 to 20 extra days. Now, the B side of Medicare, this is for everything outpatient. Scans, MRIs, CAT scans, outpatient surgery. All the doctors that you see in their office or they come to see you in the hospital are still paid on the B side of Medicare. All physicians are going to be covered through Medicare B. All right, so let's talk about what it's going to be financially for you. So everything on the B side, again, outpatient, all doctor services, durable medical equipment, those kinds of things covered through the B of Medicare. We start the year off with a deductible. Now, this deductible is a calendar year. Remember, I said this one can occur more than once in a year. This one cannot. Once a calendar year, all right, after we've met that deductible calendar year, and by the way, it resets every January. After that, then we're responsible for 20% co-insurance, 20% of the bill. So as long as you're seeing a Medicare provider and the service you're getting is covered by Medicare, Medicare covers 80% of the bill, you're responsible for 20%, called co-insurance. And the last gap is called an excess. And I want to clarify a couple things. Number one, only physicians, surgeons, specialists, primary care doctors, only docs can do excess. And this means this is a doctor that adds to the Medicare bill. So the majority of doctors do not do this. Less than 5% of doctors will charge excess. But when a doctor does charge excess, and it's going to happen some, this means that that doctor takes Medicare patients, but will not accept Medicare-approved reimbursement rates as payment in full. They're going to add to the bill, and when they add 15%, and you'd be responsible for it. All right, so those are our gaps in Medicare, 3 on the A and 3 on the B. So you can see why I say if someone has A and B only, that is a bad decision. In fact, those are the kind of things that lead to bankruptcy. All right, so the majority of people that go in the traditional Medicare don't want that kind of a liability, so they're going to transfer that liability to an insurance company. As I said earlier, top 2 plans today are G and N. So let me show you how these work. Again, you saw all the gaps we're responsible for. So when someone buys a supplemental plan G, what's happening? They're getting rid of 5 of the 6 gaps. The only thing they're responsible for is once a year, they would have to meet that B deductible that resets every January. So this year we pay the first $240 and we're done. As long as Medicare covers and we're seeing a Medicare approved provider, other than the $240, you should never see a bill again. All right? And so that's the G plan. Now let's look at the N plan. Again, we see the 6 gaps that exist in Medicare. If someone gets an N plan, they're getting 4 of the 6 gaps. They, like the G plan, are still going to be responsible for the once-a-year B deductible, but they're also going to be responsible for excess charges. And again, this does not happen often, but it can happen. But the point is, if we see a doctor that charges excess and we have the N plan, we're going to have to pay that additional 15%. In addition to that, if I have an N plan, I've got a couple copays I'm responsible for. So anytime I see a doctor, this would be a specialist, any kind of provider, primary care doctor, I'm subject to up to a $20 copay with my N plan. And if I happen to go to the emergency room, I pay a $50 copay unless I'm admitted to the hospital. Then they waive that copay. All right, so I'm just taking on a little bit more liability. Now again, we are nationwide brokers, okay, so I'm just going to give you just a general rule of thumb here. The difference in premium between the G plan and the N plan is about $30 a month. Now some states a little more, some states a little bit less, frankly, but we can save some money on that N plan, that $30 a month. So here's what I find in my 15 years in the business. People that really, that $30 doesn't make a difference, that they would just soon have the most comprehensive coverage. They don't want to worry about excess just in case that occurred. They don't want any copays. They typically go with the G plan and they'll pay that extra $30 a month. Someone who says, no, I'm going to save the money. Excess doesn't occur often. I don't go to the doctor often. I don't want to really pay. I'm all right, comfortable paying a copay. Then they may go with the N plan. But here's what I want you to see, folks. Both are great options, okay? There's not one that's better than the other. It's just a matter of what's most important to you. What are you comfortable with? What kind of risk are you comfortable? What kind of premium are you wanting? So that's the G plan and the N plan. Hey, if you're finding this video to be helpful and you would like to learn more about Medicare, you'll notice up here in the right-hand corner, there's an eye. And if you'll click on that eye, it's going to take you to a 20-minute workshop. I see people make mistakes all the time, and we don't want that to happen to you. And that's why we're giving you free access to this workshop. So go ahead, click the link, and learn more about Medicare. Now let's talk about the very best way to be able to choose the insurance company that you go with. Now I'm going to clarify something. If you get a G plan, whether you get it from ABC Insurance Company or XYZ Insurance Company, the coverage is the same. Both of those carriers are going to cover the same bills, the same type of bills, and the same amount of bills. So they're going to pay the same. Why? Medicare makes it that way. That's called standardized plans. So whether I get the G plan from this company or that company, coverage will be identical. If I get the N plan, again, whatever carrier you choose, coverage is identical. But beyond that, there's going to be differences, and that's going to be has to do with the premium, the initial premium, as well as premium increases and premium stability. So that's what I want to teach you about next. So when it comes to the initial premium, the insurance companies set the premium, of course, and there's one of three ways in which they establish that premium. One way is to be what we call a community rated policy. Community rated policy. We have another one that is called issue age policies. And the last one is attained age. Okay? Now, the majority of the states are attained age policies. There are a few that are issue, a few that are community. But what I want you to understand is that initial premium is established by that insurance company based upon how that insurance commissioner of the state allows them to rate their policies. So this one right here is going to be this. Community means everybody that has a supplemental plan in that geographical area, regardless of age, regardless of gender, regardless of health, is all going to have the same price. Okay? So they have a same price. Now, when it comes to issue age policies, what that means is that you get the premium based upon the age you are when you start the plan. So a 65-year-old is going to pay less than a 70-year-old. 67, pay a little bit more than a 65-year-old. And so it's issue age based upon when you get that policy. All right, and then attained age means, again, same thing. You're 65, your rate's going to be lower than someone that's 70. But what happens with the attained age is then that premium is going to increase a little bit every year. So this is the highest premium, that's middle, and this is going to be the lowest. Okay, so what I want you to see is how do premiums increase. So with all three of these pricing methods, all of them, folks, I want you to realize that they are going to have group increases. All of them are subject to that. This one, though, is unique in that it also can have an increase based upon age. So that 65-year-old, when they turn 66, that premiums are going to go up a little bit, maybe $3 or $4 a month or something. So it's going to go up probably 40 or 50 for the whole year, divided by 12, about $3 or $4 a month. So it starts the lowest, but it starts inching up based upon how old you are. This cannot go up because of age. It started because of age, but can't go up. And this one can't go up because of age either. But all of them can go up because of the group. So sometimes people are real confused about this. They're all going to go up because of medical inflation. And so I'm going to explain to you how premium increases occur. Again, this one was unique, was the lowest, but it'll bump up a little bit every year to offset inflation. And so premium increases happen this way. Okay, now here's what happens. When you get a MedSup plan, you are going into a group. We call that a block of business. And so depending upon how old you are, whatever rating is, they're going to give us rates from 65 to 105. All right? And so what happens in this block, we have a variety of ages within. We also have males, females, we have non-tobacco and tobacco users within the group. And so our premium is established. So what happens is the policy owners pay in their premium. All right, they pay premium in, money goes in. Well, why'd you do that? You transferred liability of the gaps to the insurance company, so therefore they're responsible to pay money out. And we call this claims, right? So money goes in and money goes out of the group. And so what's going to happen is all these groups eventually, more money is going to go out in claims than is coming in through premiums. That's going to happen. Now when? I don't know. Could happen in 1 year, 2 years, 3 years, but it's going to happen from time to time when claims exceed premiums. When that happens, they're losing money. So what this insurance company will do is they will calculate their losses. So let's say they say we are losing 5%. 95% of the claims are covered by premium, but we're losing 5%. They're protected by insurance law. They don't have to lose money. So they can take that 5% and they go right to the insurance commissioner in the usually the state capitol, and they are going to petition for a rate increase of 5%. They audit the request. If they approve the request, everybody in the group goes up 5%. You could be in here and healthy and never had a claim, or you could be in here and you're in the midst of cancer and you cost the group $100,000. Doesn't matter. Everybody goes up the equal amount, okay? And so we're going to see group increases from all three of these. This one was unique because it starts lower, goes up a little bit, and the rationale behind that is by having slight increases, then there should be less group increases. All right, so here's my point. They're all going to go up, folks, but what you want is you want a company that's rate stable, because we know things are going to go up, and what we've learned is that the larger national carriers that have more people in their groups tend to go up less drastically and less frequently than local supplemental companies or regional carriers. So we like to look at the rate history of a carrier. I had somebody recently, there was two companies they were looking at. One block of business had about 1,000 policyholders, or a little bit less than that. Another company had about 33,000 policyholders within that same area. Well, which one's going to be more stable? More than likely the larger group, because the risk is spread out to more policyholders. So my point is, when we look at a company, we look at their initial premium, but we also look at the history of their premium increases. Why? Because here's what I'm looking for, folks. I am looking for stability. Okay. Now, are rates going to go up? Sure, they're going to go up. They all do. But some companies tend to take more frequent and more drastic price increases, and we'd like to avoid those kind of companies. All right, that brings us then to really what I would consider the best way to buy a supplemental plan. You really only have two choices, folks, because anytime we buy a supplemental plan, there has to be an agent involved. And there are two types of agents. There's either captive agents, which means they work for one company and only one company. They're an employee of that company, or they're an independent broker. That's what we've chosen to do. Now, again, I feel like the independent brokers bring more options to the table because they can look at many, many carriers, not just one carrier. All right, and so I think this is the best option. And again, there has to be an agent involved. Even when you go direct with a carrier, there's still going to be an agent involved, because that's the only legal way policies can be written, is through some type of an agent. Now, what you need to understand is the insurance company does what? They set the premiums. We don't set the premiums. And so whether someone went to a captive or they an independent broker, that premium that's quoted is always going to be the same. There's not going to be any difference whatsoever. Also, the commissions that we receive are paid by the insurance company, not by you. So you don't have to worry about that. And so the price is all the same. So what you have to decide is, do I want just work with a captive, in my opinion, limited options, or work with some broker that can give me several options to look at? Because one size does not fit all, and that's certainly true in the insurance business. All right, so that completes our guide for getting Medicare supplemental plans.